All. This is Dr. Mobeen Sayed from Drbeen.com. Welcome to one more show. So once again, we have a rock star with us. So I think we have become very used to having rock stars. It's become a norm in Dr. Bean's community here. Dr. Stephen Phillips, welcome. Dr. Phillips has been with us before as well. He is the author of the book Chronic, and we talked about it last time. Guess what? That book has become the bestseller. So let me just very quickly share. I'm sorry, before giving you even a chance to introduce yourself once more, I want to share your book. I hope that is okay with you. So here is the Chronic, the book, written by Dr. Stephen Phillips, who is here with us, and Dana Parrish. And look at this, guys, Cool Beans, first #1 bestseller. So out of 30 million books that are present on Amazon, this has become a bestseller. So of course, it makes me really, really happy. And now those Cool Beans who have been here and who know me for about a year or more now, you know, this is the book I requested last time as well to buy. This is the book I'm going to say once again for you to have it. I have never tried to sell you my own products. I always kind of say, here is Drbeen.com, you can get a free trial, and then I move on. So I never push you, I never ask you to go buy it. But this is one book that I would request you that you buy it, #1. And #2, if you know some youngsters, you must have it for them. And here is why. The chronic diseases, as the name says, these are chronic diseases. They can make a person suffer for a very long time. So youngsters who develop these symptoms, they should be aware, they should be guarded, they should know it. As soon as they develop any symptoms that they see in this book, they should immediately seek help and figure out how they should not end up in a chronic state. This is why I keep saying to you that this book is very important. So my apologies, but I would request you to gift it, #1. #2, there is another uniqueness in this book. And I was talking with Dr. Phillips about it. That uniqueness is this. Dr. Phillips has written this book after himself going through the chronic disease and almost dying in that process. He shared that information last time. So it is not that he picked up a medical book and then said, okay, so here is a chronic disease and here is how you manage it, and that information is everywhere available. That's not the case. He had to, I was just speaking with him and I was saying, you had to invent your way out of it. That information cannot be in any other book. So once again, my request to you is, please, I'm very passionate about this book to be present in every household. I have no commercial interest. I have no interest other than having Dr. Phillips here and talk with you. So that is the basic discussion about the book. I'm going to very quickly introduce Dr. Phillips for those of you who are new. So Dr. Phillips, MD, is a renowned Yale-trained physician, author, international lecturer, media go-to expert, and now an author of a bestseller as well. Well published in the medical literature, he has treated over 20,000 patients with complex chronic illnesses. So I have treated about 600 COVID patients, and I am very happy that they're all healthy and happy. Imagine somebody who has treated 20,000 patients. And in about 20 countries, Dr. Phillips experienced firsthand the nightmare of an undiagnosed serious infection. After nearly dying from his own mystery illness and having to save his own life when 25 doctors could not, this is the unique part in this book that is important. Dr. Phillips, welcome.
Thank you. I am overwhelmed by your generosity. I can't.
Thank you very much. Thank you very much for this contribution. So my request to you, from last time to now, tell me in terms of the books, what has changed, what has been accomplished, what is the, where do we stand?
I mean, there's been a lot of interest in the book. You know, we set out to write this book because I wanted to change the status quo for patients with chronic illness. And truly, if I had the information in this book when I got sick, I wouldn't have gone through 2 years of living hell. And it's the book that I wish that I had, and it's the book that I want everyone to have. So we're getting calls in the office of people, you know, just saying, thank you. I read the book, it changed my life. Sometimes we hear like crying in the background. And these are people who are not patients, you know, they're just, you know, random folks who are calling and saying, wow, this book really resonated with me. I'm going to bring this to my doctor. It's exactly what we wanted. And,
Excellent.
this is innovation. So if you have a deviation from the norm, which innovation is, it's always going to get the hackles up of some people too. But that's what medicine is all about. If we don't change as we learn new things, then nothing ever changes. I mean, it's obvious. It's so.
Absolutely. So thank you very much for being here with us once more. So there are three parts of the discussion today. One is that there is a list of questions that I want to go over with you. Second is that there are questions from Cool Beans on Twitter. And then there are questions again from Cool Bean on the live as well. So there are three parts. We will try to do as best as we can in the next 1 hour. One update for the Cool Beans is that in this discussion, I am going to take your questions and put them to Dr. Phillips about vaccine and about the long hauler state and what should be done. And if somebody who is long haul COVID plus Lyme, what is the situation there and what is the best way to start managing, or what should be the approach there? So these are the kind of topics that I want to touch upon. So you ready, Dr. Phillips?
I am. Let's go.
Okay, excellent. Thank you very much. So I'm going to start with my questions. I have my list over here. So please don't mind when I look away towards my list. So the very first question, in your book, when you talk about chronic infectious diseases, the symptomatology there is very broad, right? So there are infections that are disabling or deadly, and then there are mild symptoms or fatigue or something that continues forever. What is the reason for such broad spectrum of symptoms?
There are several reasons. And so we touched upon last time that there's this huge range of numbers of infections and then subtypes of species and strains underneath the genus and species. So there's just a lot. It's a big, big family tree. And some are inherently more virulent and disease-causing, and others are kind of wimpy. But the data with animals clearly shows that if, let's say with Lyme bacteria, Biberdorferi, if you infect different animals with different HLA types, they've done this with rodents, where you take the exact same strain of Lyme bacteria, put them into rodents with different HLA types, and one gets very, very sick, one doesn't get sick at all, and the other gets a little bit sick. So you multiply that out by the strain heterogeneity and the species heterogeneity, and you get this, this curve all the way from 0 to 60. But also, even within the same genetics and the same infections, there are variables that people find it difficult to predict. I mean, look at areas that are hyperendemic for malaria. People in those areas tend, adults at least, tend not to succumb to serious bouts of malaria. But a tourist that goes and visits is more likely to get seriously ill with malaria. So in places where there's lots of brucellosis, like in the Middle East, they tend to have much higher rates of asymptomatic brucellosis. So we have other environmental factors. It's almost like a vaccination that happens, because the exposures are so common that some of them are going to be low inoculum sizes and only kind of serve to, make the person immune rather than get them ill.
Got it. Thank you. Thank you very much. So my next question is, so last time when you were on the show, you mentioned problems with diagnostic testing. So these infections, so the question is the serological testing and the direct detection of the organisms of the chronic autoimmune diseases. So I am seeing a lot that sometimes we say, hey, this is just an immune dysregulation. And sometimes we say, maybe this is a persistence of the virus or the bacteria or other such things. What is the difficulty in there, and what is the right approach?
When I think of bacterial infections, at least, I think of them as the typical fast-growing bacteria that divide every 20 minutes or so, and then the slow-growing ones that nobody really understands. And when I was sick, it was my job. I was just lying in bed for 2 years, and every day I would, almost like cold call, I would send out like 20 or 30 emails to random researchers around the world trying to figure my case out. And one of them was very nice, was an infectious disease researcher from Switzerland. And he basically said that if any doctor tells you they know what's going on with these slow-growing intracellular bacteria, they're lying. He's like, I'm top of my field, and I'm telling you right now, we don't know. Like, there's a lot missing from this puzzle. So bacteria like tuberculosis and leptospirosis and the other spirochetes like Lyme and relapsing fever spirochetes and brucellosis and Bartonella and the ones that cause Whipple's disease, These are all really weird bacteria, and there's large knowledge gaps. And part of the weirdness from most of them is that they're very hard to isolate. They're very hard to grow. So, they've been trying to grow syphilis bacteria forever from the blood of patients with syphilis. And with Lyme and some other pathogenic spirochetes, it's almost as hard to grow as syphilis. So we don't have good direct detection tests. It's not like a throat culture. And without these good direct detection tests, anybody can say anything. And it's very, very hard to prove the opposite. In the case of Lyme, I don't even know why they're fighting about that one, because it's the most, it's a very, very common infection. And they've done a ton of research on it. They've shown that they can't kill and eradicate the bacteria in animal studies. They have it alive, cultured from people. Despite its difficulties, it's been found alive from different body sites in humans after years of antibiotics, and they can't kill it in the test tube with the antibiotics that are purported to be its cure. So the fact that they're still fighting about that, I think, speaks to medical bias, because that one should be wrapped up already. But the other ones are still in areas of active research. And even with brucellosis, there are studies, like people don't really, there's not a big controversy about chronic brucellosis because it causes so many objective features, and that the person is still sick. And there are studies where they've tried to do even just PCRs, polymerase chain reaction, and they'll show like 29 negatives and 1 positive. And we'd be tempted to think, well, that 1 positive must be a false positive. But no, it's a real positive. And even PCRs don't pick up some of these infections on a regular basis.
Got it. And cool beans, while we continue to ask our questions, I also wanted to continue to add some more information as well, just to convince you that this is an important and critical topic. So here, I'm going to share, before we ask more questions, one I shared that here he is the bestseller. And check this out. Here is in the New York Times, we have a article here, the long haul COVID and the chronic illness debate. And in this discussion, there is the discussion about chronic as well, the book. Then here, I thought this was pretty interesting that Dr. Phillips has been on Dr. Oz show as well. And it is actually 7:30 minutes, and it's very interesting to hear. So if I can very quickly just play a couple of sound.
You think from an infection inciting the autoimmune disorder, if you treat the underlying infection, the army can settle down on its own. So basically, that was an analogy about how autoimmunity works, because you're still showing it. I'm sorry.
Yeah, and this was great. So once again, from the chronic diseases point of view, either there is an autoimmune issue, or there is a virus persistence, or there is both. And it was interesting that you were here as well. So I loved this one. I think we should do this more often here as well.
Have an autoimmune disease. Now those white cells kill those bacteria, but either they don't know what to do when the bacteria are dead, they get confused.
So the links to these discussions are in the description as well. So I'm going to continue with my questions. I wanted to make sure that the cool beans are aware that there are other places to listen to you a little more as well. So here is an important question. Autoimmunity, immune response, symptoms. Is it bad to treat, or is there any danger in treating the symptoms? I see this very often. People have long haul symptoms, for example, fatigue or myalgias or brain fog. Some doctors simply call it psychological issues and then dismiss them. Some simply call it, yes, we know this is the myeloencephalitis and this is a disease and here we are. Some try to treat the symptoms, some try to find what is the reason. So tell me this, symptomatic treatment, is there a danger in there?
There's a danger to immune suppression. I mean, look, there's danger to most treatments, including antimicrobials, but it's a relative risk scale. When, I had 3 rheumatologists, and one of them said, yeah, the medicines, the immunosuppressants, people do die from them. And as soon as she said that, that doesn't come out of my mouth when I'm talking about the side effects when I explain them to my patients. I'm not saying that it can't happen, that patients, God forbid, can't have a very bad outcome. But I've been in practice 25 years. I've never seen a patient die from treatment. And they do see patients die from the treatment. She said it to me, and it's obvious. It's a true thing. I mean, we know this happens. We know they can get cancer and horrible infections. And as soon as I heard, I mean, I knew that going in. I had no interest in suppressing what was previously a perfectly, functioning immune system that I was born and blessed with. And I did not want to suppress it. I think it's an upside down way of looking at things. And at the very, very best case scenario, with no bad outcomes, it's going to suppress symptoms, but it will never cure. And if you look at the other options, if you get at the cause, you have a similar scenario. You have at the very best, case scenario, you're going to reduce symptoms as you go toward a cure. So you can actually reduce the infectious cause. And that's what I see with my patients. I get more than 95% of my patients better. That's been the statistic since I opened, since 25 years ago. And I think that when I went back to the 3 rheumatologists, I don't know if I said this last time, I did a little dance in front of one of them. Because here I couldn't turn over in bed on my own. I couldn't sit up on my own. I had 24-hour home care. I didn't walk for 2 years. Go to this rheumatologist, I started dancing. I'm not a great dancer. I dance like Elaine from Seinfeld. So I'm dancing in front of this rheumatologist saying, maybe think about this for your patients. And she's like, well, listen, I can't deny that you're better, but I just can't. I can't do it. This is how I was trained. I was like, well, maybe you should learn some new training,
That's actually sad, and there is an opportunity in there as well. And I was thinking about the book before you came on. I was looking at your book once more, and I was thinking that this is not a book just for average lay folks from medicine point of view, for healthcare professionals as well, who want to manage their patients better, who may have chronic diseases, the patients.
Right.
For them, this is a great platform as well to start understanding how to approach these. Sorry, please.
No, I say that's why I put in so many references to scientific literature. I wanted it to be a learning resource if doctors would take a look. And that's really how we're going to help people. I mean, it's great to educate the patients. It's an absolute necessity. I want to empower everybody, but I want them to access to care. And right now, there's just not any access to care.
Makes sense. So the next question that I have here is, so in the book, there's a good review of infectious causes of psychiatric symptoms. It's interesting to hear that infection can cause psychiatric diseases. Why? How? And we hear this very commonly here with the long haulers as well. I am sad that part of our Cool Bean community, there are folks who are becoming long haulers. Either they were from previous Lyme disease or so, or now with COVID, and a lot of them have psychiatric issues. Tell me what happens.
Well, I think that it's unusual that psychiatry is one of the only fields where they're studying this organ, the brain, and they don't look at really the physical causes of the potential, organic causes of psychiatric illness so much. They focus on trauma, which is very, very important. We actually have a whole section about trauma in the book because patients with chronic illness, go through trauma. But there are many, many infections that induce psychiatric changes. The list goes from viral insults to parasitic to bacterial. It's a huge list, and there can sometimes be autoimmunity to the central nervous system also. So it's not an either or when you talk about infection and autoimmune disease. Most or many infections induce autoimmune changes, and it kind of like a snowball effect. And when you see that in the central nervous system, in children, a lot of times you get this PANS, pediatric acute onset neuropsychiatric syndrome, and kids will turn in a second from, sweet and darling to, ragey and very, very obsessive and fearful and acting out and sometimes violent. And it's an organic problem. It has nothing to do with, trauma in these cases. And I just don't see a difference. Like if someone is numb in the part of their brain that causes numbness in their hand, or if they're numb in the part of the brain that causes them to not have joy, and then they're depressed, how different is that? It's the same brain. It's just two sides of the same coin. And I can tell you that I cannot count how many patients have come in on psychiatric medicines and leave not on psychiatric medicines.
Excellent. I love that. So the topic in your book, the mending your mind, can you connect that topic with this discussion that we just had?
Yeah. I always said if I wasn't a doctor, I'd be an EMDR spokesperson, because when I went back to practice in 2013, I couldn't talk about my illness, and I'd start crying immediately as soon as I talked about it. And I did EMDR in one session on my own, which I'm not recommending for people because I know it's bad to recommend like YouTube self-administered EMDR, but it worked for me. And I was able to talk about my illness the next day and ended up writing a book about it. Then my brother died from a heart attack in July, and I cried for 5 months straight. I did EMDR online, and it didn't help. Ended up making an appointment with a psychologist and did EMDR with a psychologist. Within 3 sessions, I'm back to normal, and as normal as you can be when you lose your brother. And I love EMDR because it's a durable fix, it's drug-free, and it's fast as lightning when it works. And you say, well, how many patients does it work for? What's the majority? It works for the vast majority of people that use it. I send my patients to these trauma therapists on a regular basis, and they go off like 6 psych drugs. It's a great, great therapy, and I couldn't speak highly enough about it.
Got it. Got it. Thank you very much. One more question. Just have a couple of more questions, then we'll go for the cool bean questions as well. One question is about the infection spread. So we talk, all of us, I think, have this thought in our mind that it is the bugs that transmit these. Are there other ways for these infections to be spread as well?
Yeah, so many of them are not typically even spread by bug bites. People get toxoplasmosis, a parasitic infection, by eating undercooked meat. People get strongyloides by touching soil. People get Coxiella, which is Q fever, by inhaling these organisms. So bug bites do spread a lot of infections, but people should realize that they can get, infections that can cause chronic illness literally anywhere in the world, and if they never have a bug bite. There's also other modes of infection that aren't really discussed very much, like transplacental, mother to child. There are many, many of the zoonotic infections that are well recognized and accepted to be spread from mother to baby. And obviously syphilis is the poster child for, transplacental transmission infections. And Lyme, this very, very close cousin, they fight about it. Anything related to Lyme, they fight. It's the most ridiculous situation because leptospirosis is, another spirochete that's accepted to be transplacental. It's got far less data than Lyme does. Lyme babies have been born dead, and they've found Lyme bacteria throughout their bodies, and they still don't believe that this it's published in major medical journals. It's the most outrageous situation, but it's a very, very political disease. And then there's also question marks about sexual transmission. Some of them we know, like brucellosis, can be sexually transmitted. That's been documented. Lyme is a spirochete. Can that be sexually transmitted? They found these spirochetes in semen and in vaginal secretions. And there's, PCR data between partners that was very suggestive of Lyme transmission. And in animal studies, it showed transmission. So it's another taboo topic. I just want to broach the subject. And people say, what do I do? What do I do? Do I freak out? I'm like, no, don't freak out. Yeah, I think that, if it does model things like syphilis, syphilis becomes less transmissible as it ages, not more. And, it's like looking at patients who've been a partner from somebody with hepatitis C. If they haven't caught it in 20 years, they don't really recommend specific precautions. Everybody gets treated with hepatitis C anyway when they find out. But in the old days,
Got it. Thank you very much. Just a couple of more questions. One is about the ivermectin. So bringing the discussion to more recent things. So ivermectin has been proposed for COVID prevention, even for treatment, and then for long haul as well, or long COVID as well. Any updates on the ivermectin, its mechanism, its role in chronic diseases, maybe in the context of COVID?
I love ivermectin. I mean, I've been a big fan. When I treat COVID patients, which I offer my COVID patients treatment early, I could say that, number one, nobody's progressed to the point of needing hospitalization. I offer my patients a cocktail of prescription medicines. I also offer them a cocktail of over-the-counter supplements. I do think that zinc adds to it. I have patients, when I give them doxy and ivermectin, I put them on quercetin and bromelain and vitamin C and vitamin D and zinc and the whole bit. I don't just limit to the prescriptions. But interestingly enough, none of the patients that I've seen have gotten long COVID symptoms. And statistically, 1/3 of them should have. So I do think that early treatment not only improves outcomes in terms of mortality, somebody needs to do a study on early treatment and the development of chronic illness, because I think it's a big, big issue that we need answers.
Got it. And I think this morning I was speaking with a number of doctors from FLCCC who are leading. and they were talking about the studies that are going to be conducted about this. So
Right.
that's a very good point. Have you seen actually specifically somebody with long COVID using ivermectin and maybe having Lyme type or another previous illness with that as well? And is there any care in managing them?
So I have experience with ivermectin way before COVID came around. And ivermectin as an antiparasitic is a well-known thing, but now with COVID, it's starting to become known that aside from its antiviral activities, it's also an immune modulator. So I had used it in the past for strongyloides, which is the number one treatment for strongyloides. But in addition, it's a parasitic infection. But in addition to that, I had used it as an immune modulator, sometimes adjunctively with antimicrobial therapy, not really thinking that ivermectin has antibacterial activity for the infections that I was using it, but it really can help people get over some of these illnesses. And I was having people take ivermectin once a week. And I have this, that's why I have this amazing, comfort level with its safety, because I was using it for the past, almost 8 years in patients. So in terms of long COVID, I have limited experience prescribing ivermectin, but I have with one patient of mine who is a long COVID patient. She did not see me early on when she had COVID, and she didn't call the office, and she went to her primary care doctor. And then she called me a few months later, very desperate, that she had pain when she breathed and she had shortness of breath. And I gave her ivermectin. She turned around in 24 hours, and she was good for 2-3 months. And relapsed, gave her ivermectin again, and she turned around in 24 hours. So I do think that it's a helpful treatment and should be more studied. I know there was a preprint that I read from, I think, someone in South America on ivermectin. I must have seen that. That may be good for long COVID.
Got it. And my own experience is that anyone who's been taking ivermectin before, great that they do not become long haulers. And long haulers who are taking ivermectin, they report very good results as well. The question is really, in the long run, do they relapse or not? Does it really help finish off the maybe the persistent virus or immune dysregulation? So that still needs to be seen. One final question, and then I'm going to go to the live talk over here. Last time when we talked about your book, the COVID chapter was still under construction. Where can people find that chapter now?
Yeah, so as we were finishing up the book, COVID exploded, and we met the deadline for getting the COVID chapter into the Kindle version and the Audible book, but the first printing had already been printed. So, and they printed a lot of books. So the COVID chapter's downloadable for free at thechronicbook.com. It's the book's website. And this way, people who have the hardcover should realize that they will have access to the COVID chapter.
Got it. Cool. So thank you very much. And these were my questions that I had over here. I want to look at some of the questions from the cool beans here. So I'm going to share my screen as well, so I can show some of the questions on the Twitter side. And I'm going to take some questions here on the YouTube side as well. So here on the Twitter, while I get you started on the Twitter side, I'll then go and scan the YouTube. So here we have Avox, Mocha Bean. So Avox, thank you very much. Avox has offered he used to be Coffee Bean, and he has given Coffee Bean to Dr. Corey. And so Avox is now Mocha Bean. So Avox, thank you very much. So Avox has a question for you, Dr. Phillips. Crude case history. I know of 40 years, female, 2014, a virus complicated by pre-existing Lyme disease, damaged autonomic nervous system, and caused Addison's disease. Now diagnosed with pan-dysautonomia, 6 years bedbound, unable to sit up, lives in UK. Any suggestion?
Well, it's a suggestion for care with complex cases. It's impossible because it takes a while to unravel things like this. I can just generally comment that dysautonomia has been published with Lyme. When I see it in my patients, it's more of a feature that you see like the worst case scenarios, POTS, like postural orthostatic tachycardic syndrome type situations with Bartonella. So when I was sick, I had so many things, and it's hard to even relate all aspects of it, but my resting heart rate was 120. My resting heart rate now is 60. And when I would stand up, it went up to 160. And so this lack of control with the autonomic nervous system is just haywire, because the small, it's basically a small fiber neuropathy throughout the body. And we just lose control of these very, very basic functions. And it's incredibly disabling, and just, a lot of suffering goes on. So I would say that, I don't know doctors in the UK, but certainly this person deserves care. The question is, how does COVID play into this? Is this direct, additional damage from the virus, or there is some new data that COVID can reactivate latent infections? A lot of people were suspicious about this because I'm hearing from, again, patients who are not mine, who are not treated by me, but just what we call them Lyme plus patients in general, saying that their prior vector-borne illness symptoms were much, much worse since COVID. So I do think that it's quite likely that COVID does reactivate some latent or dormant infections, and people with complex issues like this would have to look at both sides. They would have to look: is there persistent virus, and could something like ivermectin help? And and also the Lyme component.
So our dear Mocha Bean Avox has put some more data out here as well. I like the last part. He's saying that now fundraising to get treatment in the USA. And Avox, I would think that the person to come to would be Dr. Phillips. And again, I'll keep repeating, I have no financial interest over here. I am not trying to do some financial favors to Dr. Phillips. Neither has he ever asked me for this. I just think that this is an important time, and he is a guru of this area, and we should have his expertise available to as many as we can. On the YouTube live, we have a question from Jenna Taylor. Jenna says, so Jenna, good to see you here. I was worried about you yesterday. There were some other cool beans who were talking about you yesterday as well. So good to see you. Jenna's question, Dr. Phillips, do you have advice for patients with COVID immune deficiency going for my first IVIG infusion tomorrow? And Jenna is a long COVID, I think.
Okay. So that was the question I was going to ask was, it depends if this common variable immune deficiency is causing symptoms or not, because some people, have low immunoglobulin levels and they just don't really get very, very sick. And then other people, they're sick constantly. So that's how I usually determine how I give advice to people about IVIG, because it's not a picnic to go through. It's not the worst thing in the world, but it's not fantastic either. And there are risks from that. So, but if somebody has long COVID, it adds an additional layer of complexity to the issue. I would assume that they're going to be getting some passive immunity from antibodies that other people have made and successfully fought off COVID. So, I mean, I would say good luck, and fingers crossed, things work out well. And I think that it may help.
And Jenna, thank you very much for this question. I know that from your messages here that you have been going through the long COVID and you have tried ivermectin as well, short doses before, I think now full doses. So if you care, please, as much as you want to explain that as well, we can probably put that to Dr. Phillips over here. I'm going to continue scanning the questions here to see if I can put more questions to you before I go back to Twitter. So Jody is a cool bean as well. She's saying, I sent a message to Dr. Phillips on this site asking for consult, did not hear back. What is the best way to get consultation? Also just downloaded the book.
Oh, I'm sorry. I know my secretaries have been just overloaded. We usually get, on a typical day before the book came out, we were getting 400 or 500 phone calls per day. And that's just our average day. So, and I think it's a lot worse now. So I'm very, very sorry that someone didn't get back to you. I will, remember your name, and I'll send a message over.
There is another cool bean here on Twitter as well, who was complaining about the same thing. So we'll look into that in a few seconds. Hopefully you can remember two names.
Okay. So write them down. I'll write down Jody first.
So if you can, totally cool if you wanted to pass on this question. Colin Hamill, I think he's from UK. He's a cool bean as well. Yeah. Question, can cannabis oil help with some of these brain states?
I'm not anti-cannabis. I think it's it's an example of a drug with lots and lots of potential that's been stigmatized for way too long, and it needs to be studied. It's the same with these what are considered the illicit drugs, the psychedelics, and such amazing potential benefits, and everything has to be used in appropriate context. But I don't know which brain states that I would ask which brain states is referring to. Like I can tell you, some people with intractable insomnia, I've seen them get great benefit from medical marijuana. And it's an unfortunate irony that, bad sleep disturbance is frequently part of these illnesses. When I was sick, I used to lay there in bed and I couldn't believe that I would see the sun rise and it would see 8 in the morning. And I was like, I just did not sleep the whole night. It's not like the doctors didn't give me sleep medicines. They just didn't work. And how do you heal when you're not sleeping? It's I really think it's almost like when a mouse gets toxoplasmosis and then they get disinhibited so the cat can find them and eat them, and it perpetuates the life cycle. I almost feel that these organisms do something similar. They make the person sleep deprived so they become immune suppressed further, and then it's harder to eradicate them. So I think it's an evolutionary advantage.
Interesting. So we have Rima Van Hill here. I think she's a cool bean from Europe. So I have been interacting with the cool bean so much that now I even know where they're from. Rima, I hope I'm correct in saying that. So I think her question is about ivermectin. Can it help with Lyme? Do you have any experience of ivermectin with Lyme specifically?
I do. I've used it as an adjunct for antimicrobials for the past 8 years or so. My personal experience with ivermectin is that a doctor gave it to me. I already filed for disability. I was supposed to leave the office on June 15th. The doctor gave me ivermectin at a high dose on, I think, May 29th or 30th. And I had to be carried out of the office in 4 days later. And I was put to bed. I was like, yay, I had a Herxheimer, biggest ever. And I thought it would get better. It never did. 4 months later, I still, was horribly, horribly ill. And then fast forward a year and a half, and I got much, much better. I'm like, I'm going to try ivermectin again because I hate a mystery. And I figure I'm so much better now. I'm going to be prepared for whatever flare-up it happens. And nothing happened. Not just did nothing happen, I felt fantastic. And I think that's what happens when you immune potentiate, when you get rid of the kind of abnormal immune stimulation and get rid of the abnormal immune suppression, a flatline kind of immune system. We all want to have a nice, strong immune system. But if you have a large infectious burden, it can really flare people up unless it goes slow. So yes, I have used it. I think you have to have special care with patients with demyelination, is what I wanted to say, because ivermectin is also being studied as a remyelinating agent. It's can induce the growth back of the lining around nerves. And paradoxically, in my experience, when we use it with MS patients, it flares them up like crazy. And we have to go extremely slowly. And then they get a net benefit, but it can take like a year to get up to full dose. And that's my experience with ivermectin.
Very interesting. I did not know this MS part. Catherine Coppin, Dr. Bean, I am in New York, UK. How do I get ivermectin? So very quickly, Catherine, I believe that in UK, ivermectin is not as easily available as in the US. Fortunate for the US, and still it is a lot restricted here as well. I believe that there are some sites from India that would ship ivermectin for you. So if you go to existence.com, so if you check out my videos a couple of days ago, in the description, there is a link to flccc.net. Over there on their front page, there is a button that says how to get ivermectin. If you click on that button, there are international websites available as well, and you can see which website from India you can order. So sorry, I am doing this service as well while we are talking. Ali Ji has a question. Any time restrictions after vaccination for couples who want to plan for a baby?
Oh, and talk about the COVID vaccine, I'm assuming, right?
Yes.
Yeah, it's a good question. I've not heard of any. But I don't claim to have, I don't do general medicine, so I haven't been advising my patients in that regard. So I'm not sure.
Got it. So thank you very much. What I know, and Aliji, again, my opinion is my opinion. What I know is that it is actually fine. There is no issue. And even antibodies, IgGs, can be transmitted to baby who's developing, and it actually is protective. Okay, so Tube Sterini says, for how long is it safe to take ivermectin? So again, ivermectin, we are a lot more passionate about it.
I don't know that they've defined a maximum duration of safety, but I've not seen anything bad, and it's historically an exceptionally safe drug. and it's been used in billions of doses around the world. So there's really, I have not seen a single red flag. And people, the question is, how long is it safe to take Tylenol? How long is it? Tylenol is one of the most dangerous drugs around, and people pop it over the counter. So I would say it's safer than that.
It's pretty safe. 3.75 billion doses and not much side effects. Steve Manfred, do you have a directory of physicians who will do chronic workups on patients such as you discuss in your book? I'd need someone near the Twin Cities or Western, I think Minneapolis or Wisconsin.
Right. So there's a Lyme group, the Twin Cities Lyme group near Minneapolis, headed by Lisa Nigerian, who's quite nice and a friend. And I'm sure they have a directory local that will look for these other infections as well. The thing with doctors that do what I do is a very heterogeneous crowd. And, we don't learn this stuff in med school. And I wish we did, So doctors tend to approach these things with different skill sets. I come from a research background, and other doctors come from alternative medicine backgrounds or just family practice backgrounds or something like this. And it's just that, and that influences how we approach the same problem.
Got it. Thank you. Lynn Sherb says, congenital Lyme. If a child doesn't present with symptoms until teenage years, would the Lyme infection be considered in a disseminated chronic state, or are they at the beginning of their disease process?
Well, it's making the assumption that the child's been infected congenitally. So if somebody is born, let's say, to a mom who has Lyme and develops normally until they're 18 and then gets Lyme or presents with Lyme symptoms, you say which is more likely to be the case, that the person was congenitally infected or they got acquired from some bite that they didn't know. I'd say it's more likely that it was not congenital at that point. I can tell you that congenital infections don't always have to cause symptoms. They can cause symptoms with a delay, and they can cause symptoms that are horrible. I've seen really unusual things happen in some cases of patients who have children from, who have these illnesses. But that one, I would say that I wouldn't, I just wouldn't say there's a way to say that this is congenital when it happened 18 years later. I would just have to punt that one.
So I have a question. Some of the cool beans who have reached out to you looked at the way their treatment and management will be. So question I have for you is, what are the chances of the Hersheimer reaction, and how do a healthcare professional who is managing such patients approach that? How do you approach them?
Yeah, it's about 80% of patients, in my experience, have some Hersheimer reaction, and you don't know how people are going to respond. I have patients who we give them relatively mild treatments and they run fevers and they feel like they have to go to the emergency room and it's horrible. And other people, it's more mild. So when I was younger, I was treating patients more aggressively from the get-go. And I said, I'm not doing patients any service if half my patients will run away in fear because I sent them to the emergency room after the first visit. So now we do things in layers, treat patients very mildly at the beginning. And we go up. I do things in pulse therapy, which is intermittent rounds of antibiotics. And for spirochetal infections, it's a perfect natural fit because they don't develop resistance to antibiotics and they come out of these altered states called persistiforms. And it's like they come out and you just slice a layer off and then they run back inside. You slice a layer off. It works very, very well. And even for infections that work in slightly different ways, like Bartonella, for my example, I think I said this last time I was here, I was on 3 different antibiotics for over a year. I was just so happy to walk again. And then I went off 1 or 2 days later and I got stuck in the back of Restaurant Depot. And I barely made it out of there without, the help of my friends. So I ended up doing some pulses, some rounds of antibiotics rather than continuous. And I got through this situation where I would get a rapid relapse when I went off. So I'm not married to any one form of therapy for people. It really is a highly individualized way of treating, which doctors just inherently don't like because we want to make everything a cookbook that could be generalizable to everyone else. But how do you generalize a situation where you have, 25, big contenders as pathogens, and each of those contenders has a really large family of many, many hundreds of strains. And then you get the HLA variability between patients and their other environmental exposures, and not to mention how people are metabolizing drugs differently with P450, polymorphisms. It's like you cannot predict. And so doctors don't like that. They want it to be clean and simple, but it's messy and dirty.
Makes sense. I understand. Thank you very much. One more question. I think it's a follow-up to your question, which fascinated me as well. So let's look at this question. It actually is similar for me too. So John Masley says, is Dr. Phillips theorizing that ivermectin can contribute to remyelination?
Well, other people have theorized it's being studied. So it's they're actively studying derivatives of ivermectin to remyelinate.
Excellent.
But the caveat is, from what I've seen, is that, because ivermectin kind of normalizes the immune response, and some of these, I think there's a heavy infectious disease relationship with MS. I've been treating MS patients forever, and if you give MS patients ivermectin too much too soon, I've seen a doubling of brain lesions within a month of low dose ivermectin. So I've seen some really, really hardcore stuff. So I do think it's helpful. I just think it has to be done extremely slowly, with really good informed consent and over the long term.
Got it. So here is a good question that I was asking you before as well. So here comes from Mike. So Mike, I was asking Dr. Phillips this question too. So how about vaccination? Do you have a favorite vaccine? Are you going to get vaccinated or not?
Yes. So my favorite thus far is Novavax. I was offered the RNA vaccines when they first came out, and I didn't want to be first in line. And I'm, telling people that candidly. I'm not anti-vax. I'm not, but I do question things. I question everything. And I'm so annoyed that you can't question anything today. I question everything. It's just the way I am. And so I have questions, like a normal person would have questions. So I feel more comfortable with the traditional vaccine. I'm not saying the RNA vaccines won't be good long-term, but the bottom line is nobody really knows. They haven't been studied long-term. So if anybody wants to send me hate mail because we don't know what they're going to be like, I'll say, okay, where's your crystal ball? I'd rather go with a traditional vaccine for myself, but I'm not advising my patients to wait, because I cannot do that. I'm not going to say wait and then get COVID, God forbid. I'm just saying this is what I'm doing just for my personal choice. And I just want to tell people that both my parents, who are 88 years old, both had 2 shots of the RNA vaccine.
Got it. And what I have learned from discussing these topics is we're going to get hate mail and love mail with each topic. Okay. So this is just how the life is. So I have another question. Siddhartha is a cool bean from New York. How accurate or inaccurate are diagnostic tests for Lyme disease?
They're awful. They're in a nutshell, they're awful. They're highly variable between labs. And then if you send the same blood on the same day from the same patient to 5 different labs, you get 5 different answers. And I've done it. It's been reported, and I didn't believe the reports. So I did it in my office with like 50 patients when I first opened, and I was blown away. And on top of that, there are criteria that are overly stringent called Cdc Surveillance Criteria. And I don't know if anyone's heard that the estimates for Lyme all of a sudden in the country jumped by a factor of 10 overnight. Is because the CDC made an admission that their criteria fails to capture 90% of Lyme cases. So the natural question is, why do you have a criteria that fails to capture 90% of Lyme cases? What kind of criteria is that? And there was a meta-analysis of 8 studies that was discussed and put up where the overall sensitivity rate for Lyme testing was 50%. So if you compare that to HIV testing, where it's 99.97%, and you got this Lyme test with 50%, it's a scandal. If it was any other disease where people weren't, dismissed and marginalized and made fun of and everything else, they'd be rioting in the streets. But this Lyme community is really, really getting the short end of the stick.
So what I'm going to do is this. I want to give some more time to the live audience. So I'm going to ask one more question from here. Then let's try to do a rapid fire questions for Twitter, because these folks have put the questions out for 2 weeks now. I don't want to ignore them. And then we'll come back if we have more time. So one more question here on the live side. Susan Pick says, so what are doctors' plan on how they're going to address symptoms of fatigue, insomnia, etc., who are autoimmune patients such as Graves, Addison's, MS, etc., the same as long haulers?
Well, like I said, insomnia. I mean, I like to treat with supplements when I can. Before I got sick, I didn't really think that supplements were all that effective. And then when you get sick, all your biases kind of like fall away. And I was ordering every supplement in the middle of the night. But I found that the amino acids like L-theanine and ornithine and tryptophan and glycine could be really helpful in having people get restorative sleep. And when people are over the age of 40, we start talking about a combination of immediate and time-release melatonin. And in terms of Graves' and Hashimoto's both, I have found consistently a reduction of autoimmune markers for thyroiditis when patients are treated. So I've had many, many patients who've had Hashimoto's. They're stable for years. All of a sudden they get, Lyme or one of the other infections, and their Hashimoto's is now brittle. They go up a little bit on the Synthroid and it's too fast. They go down a little bit and it's too slow, and they just can never normalize. They're constantly changing and chasing around their thyroid levels. And once they're treated, I've seen that become unbrittle again, where they're just stable on their thyroid meds.
Got it. Thank you very much. So I'm going to go to Twitter. Let's see if we can try to answer as many as quickly. So Michelle says, and Michelle is a very good cool bean. She says, all cool beans are very good cool beans. Does it cover chronic conditions for pediatrics? So the book.
Yes, I mean, a little bit. I'm not a pediatric doctor and only see patients down to 16, but I see 16-year-olds who have had very extensive pediatric conditions. And the main pediatric condition that we see is PANS. And again, pediatric acute onset neuropsychiatric syndrome, they used to call it PANDAS, which was more focal to strep as a syndrome. But now they're finding there's other infections besides strep, so they made the name more general. And these patients frequently have autoimmune markers against central nervous system proteins, and they could be okay and moderate to treat, but they can be among the most difficult patients to treat.
I understand. And Michelle, for your second part of the questions, I would respond to them later on. One is about Israel and their situation with the vaccination and the children, the time part. So Mark Zapp says, should we, and from his questions, it seems like he may be an MD himself. I'm not sure. Mark Zapp says, should we be testing vaccine-induced Bell's palsy and other neurological symptoms for Lyme positive, as this may be stress reaction with underlying chronic disease?
That's a great question. So underlying chronic disease or underlying chronic infection not previously producing disease. So, part of this thing that we stress in the book and the reality of stuff is that we're all walking zoos, and many of us have chronic infections that don't make us sick. But what happens when something tips the cart over? Can a bad viral insult or can an immunologic state related to vaccine do that? And I think the answer is probably yes. I have seen unusual vaccine reactions in the past, but I haven't seen them in patients who've been under my care. Any of the vaccine reactions that I've seen that have been very, very bizarre were all part of patients' histories before they came to see me. And once I started treating them, I haven't seen bad vaccine reactions.
So can I infer from your answer that if somebody had chronic disease and they were being treated, then vaccines reactions are lesser?
Yes. And I would also, but specifically address Mark's question, I do think that it's a good idea if somebody would develop Bell's palsy after a vaccine, I would evaluate that person for Lyme.
Got it. Thank you very much. Denise TG13, you ask him, so this is your next cool bean who you may have to take down their name. You ask him why he never responds to my appointment request from his website.
It's okay. And I would ask if Jody also had a problem through the website, because my administrator did say that she thinks there's something with the website. So for people who are having problems, if you could just please call and leave a message if Jody, if that was a problem as well for you. And if it's a website.
Is the phone number on the website?
Yes, I'm sure, but it's 203-544-0005. Easy number to remember.
Excellent. Thank you. And in the description of the video, last time Dr. Phillips had shared his contacts. All of them are present in the description as well. Scott Robinson says, in the book, Dr. Phillips discusses the Hersheimer reaction. We'll know in bacterial infection. Could any reports of vaccine deaths be related to this, given that they consist of viral RNA? Totally up to you to say pass or
well, I mean, I don't pass on any question, because I always say that I would never stop a person from asking a reasonable question. I think it's a reasonable question. It wouldn't be a Herxheimer reaction, because Herxheimer reactions are strictly defined by the presence of antibiotic and a bacteria that produces a Herxheimer, and spirochetes and Bartonella and Brucella and Coxiella, and sometimes tularemia can produce Herxheimer type reactions. It's not just syphilis, the spirochetes. But it speaks toward the other comment about seeing weird reactions in patients of mine before they were treated, and is it because they had some strengthening of their immune response, some inflammatory reaction, and when the immune system wakes up, keep in mind that it's in the interest of these organisms to keep relatively quiet. Even though they cause chronic inflammation, they are orders of magnitude less inflammatory than routine bacteria like strep and staph and E. coli or what have you. I mean, there's no comparison with the amount of inflammation that if they're present in the bloodstream, that they will cause so much less compared to a regular non-fastidious bacteria.
You got it.
So I do think that, all bets are off when it comes to these crazy reactions that are being seen. I'm not really sure.
Mark Zapp says, are viral static treatments used in COVID useful in rheumatoid arthritis, for example, melatonin, ivermectin, zinc, ionophore, turmeric?
Well, turmeric and ivermectin, in my experience, certainly are. And again, one of my diagnoses was rheumatoid arthritis. Ivermectin, flared me up like crazy, like I said before, and then made me feel fantastic. And I've taken it for COVID prophylaxis a number of times. I look forward to my vitamin gummies and my ivermectin because,
Me too.
Yeah.
Excellent.
Yeah.
Scott Robinson, Dr. Phillips discusses the Herxheimer reaction occurring when requested bacteria are killed en masse by antibiotics, sequestered bacteria. Any parallel with reported complications of vaccinations?
I think that's a similar question to what was answered before. I'm not really sure. I would answer it honestly if I knew. I don't dismiss anything and I take everything seriously.
Yeah.
People ask me and I say, look, the best, most honest response is to say, I'm not really sure what's going on. But I know. Yeah, okay.
Mark Zapp says, is tinnitus a vector-borne disease? Do you have recommendations for treatment?
Well, it's not a vector-borne infection. It's a symptom, and it can be a symptom of many vector-borne infections. So I had, I don't even think it's in my book. My story for the book, I edited down like 4 times because it was too huge. But I lost my hearing about, 4 or 5 times. One time it was 80% hearing loss in one ear with nothing but ringing and fullness and echoing. It was horrible. And I have patients like that. So, when people get sudden sensory hearing loss, tinnitus, vertigo, these are all, symptoms on a spectrum with dysfunction of the nerve that supplies, it goes to the ear. And if you look at people with Meniere's disease or Meniere's syndrome, there's a lot of correlation with Lyme. And I've seen patients come in with that triad, many times. And when you look at patients with sudden sensory neural hearing loss, the outcomes are about 50-50. Like they only get their hearing back about 50% of the time. And in myself, my hearing is perfect. And in my patients in whom it's happened while they've been under my care, I've treated them with antibiotics, and the ENT doctors routinely give them steroids. But again, it only works like 50% of the time. And under my care with the antibiotics and the steroids, I've gotten, knock wood, 100% of the patients have gotten their hearing back.
Got it. The next few questions from Mark Zapp seems like we should request Mark to get the book as well and read up some of that over there too. The questions are, what protocol would you recommend for early treatment of Lyme? I think you have touched on that in your book as well.
Yeah, so for erythema migrans stage disease, I treat more aggressively than most, primary care doctors. I look at that as an opportunity, and if you miss it, it's an opportunity lost. So we know that treating 3 to 4 weeks of doxycycline is associated with bad outcomes in, average somewhere between 20 and 40% is what most studies are showing. And some conservative medical societies, I don't like to use the word conservative, but let me just call them wrong, but some medical societies keep quoting 5 to 10%. Where they get that information from, I have no idea. I found one study where it was a 5% bad outcome rate, and they had erythema migrans for 7 days or less and absolutely no disseminated symptoms. So it was a very, very select population.
Got it.
Most people have symptoms, of dissemination, even with erythema migrans. So I treat with Doxy plus Zithromax in a nutshell for 4 weeks. I treat with 2 antibiotics, and then I have them go off and I do a few rounds of what I call pulses of doing 2 weeks on, 2 weeks off. to try and catch any of the remnant, bacteria that are still left over from the initial month.
Got it. Thank you very much. And for the listeners, once again, please, these are especially medications for the chronic diseases, especially chronic infectious diseases, can cause Herxheimer-like reactions or can cause severe reactions, which can be quite dangerous. So please do not use this discussion as a advice or prescription. This is just for an educational concept here and presentation here. Please talk with your doctor, reach out to Dr. Phillips, and that is how you move forward. Mark Sapp has one more question. I have a patient with MS and an exacerbation of glossopharyngeal neuritis from a COVID-19 vaccine. Do you have any treatment recommendations?
I do not. I think it's interesting because, when I look at an MS patient, I'm looking at a spirochetal infection waiting to be discovered. If it's a relapsing or remitting MS patient, I've seen a huge correlation with spirochetes and with improvements with antimicrobial therapy. Primary progressive, it's a bit of a different story. So we don't actually accept primary progressive patients in my office because the outcomes only get like 10 to 15% better. We'll get with the regular relapsing and remitting MS patients, we get more than 90% better. But it's interesting. It's almost like on the same spectrum of people having unusual reactions. Do they have an infectious route to the MS? And is that flaring up with the vaccine?
Yeah, it is possible.
Yeah.
Next question from Mark. Have you used silver for Lyme positive treatment?
I have not.
And next question from Mark, last one from here, and then we'll answer some questions on the live side. What protocol would you recommend for suspected chronic Lyme plus pulse doxycycline? Is there something in the book? Can we request Mark to look up?
There's some stuff in the book. We had to keep the protocol simple because it would be really very long. It would be hundreds of pages, and it's not a protocol like a cookbook. It's kind of like, it's called like a self-correcting algorithm based on patient response. So no patients are treated identically because the patients respond differently. It's like, I don't want to beat my head against the wall and use something that's not working. I don't know if I said this last time, but I have 2 nurse practitioners, and one patient had seen one of my nurse practitioners a few years ago. And after the first visit, he wanted to speak to me because he was really crying and he was upset. And I said, was the visit that bad? He's like, no, the visit was great. She's amazing. I said, well, why are you crying? He goes, she told me to go off doxy and rifampin, and I've been on it for 6 months. And I said, how are you feeling on it? He's like, terrible, no better at all. I'm like, well, why would you want to stay on it? And he said, because his prior doctor told him it was the only treatment for Bartonella and there's nothing else. So I just think that, we have to be open in our assessments of people.
Got it. So I'm back on the live side. We are above an hour, so I'm going to take some more questions and then we'll call it a day for today. I know that you're on the East Coast. It is late on your side as well. So there is a question, and I wanted to answer this one. Carolyn has a question as well. Can ivermectin help tinnitus caused by vancomycin adverse reactions? So before you answer that, my apologies for this. I want to answer one more question about the neurological symptoms with COVID. And Dr. Drew had reported that with his own tinnitus, he used fluvoxamine and it was great. Dr. Syed Haider a few days ago reported that with ivermectin and combining with fluvoxamine had great outcomes. Fluvoxamine has a possibility of suicidal thoughts and increasing of those thoughts. So please make sure that you do not take that without a doctor's advice. But for COVID, ivermectin's combination with fluvoxamine has been very interesting and the reports are great. So sorry, Dr. Phillips, back to you. How about this question?
So vancomycin is a little bit ototoxic. It's a little bit toxic to the ear. So I don't know that ivermectin would help unless, the toxicity can involve something like remyelination. And obviously if there's acute inflammation or chronic inflammation in that area because of damage, so there are many, I guess it really depends on what the mechanism is. Is it direct toxicity that's oxidative mediated and then it's damage to a nerve, and will the nerve grow back with remyelination? It's all very, very researchy and theoretical. I would say that if I was stuck with chronic tinnitus and I wanted to try things that are safe, it's a risk-benefit analysis like anything else, but I wouldn't say there's a big wealth of data to draw from.
Got it. Thank you very much for that. Let's see if we can take a couple of more questions from here. Let's see. So there is a fluvoxamine question and long haulers. I'm gonna. Venti is saying that Chronic is Dr. Phillips' book on Amazon. So yes, not only it is on Amazon, it is at this time it is a bestseller as well. And the link to that book is in the description of this video. And you can actually just go and Google it as well. I Googled Chronic, the book, and it came up. So there's a question from Mainly. Is myositis a possibility of tick bug?
Yes, that's an easy one. I could say yes for that. I could expound, of course, but many of the vector-borne illnesses can cause myositis. I see it all the time.
Absolutely. Yeah. So, Dr. Phillips, thank you very much for your presence once again. We learn a lot, and I feel that, one, you have created such a wealth of knowledge. You practice with that as well. You have written that in a book as well. And then coming here and then sharing that with nurses, with doctors, with medical students, and with general public. Thank you very much for your contribution.
Thank you so much for having me. It is a pleasure, and I'm very appreciative.
Thank you. And my parting message once again, Cool Beans, if ever you can do something for me, that would be please buy this book. You would not regret it. Whoever you would gift it as well, they would actually be protected by you. And thank you very much for this gesture. And once again, I would see you in a chit chat in a few minutes. Please like, subscribe, and share. I was looking at previous video from Dr. Phillips, and I saw that 10, 11,000 views. That should not happen with this kind of a topic. So please share this as well. And I would see you in a few minutes in chit chat. Thank you very much, Dr. Phillips.
Thank you.